All right, let's begin. Hello, welcome to this webinar that we called Future Challenges in Clinical Laboratory Analysis as a consequence of Big Data and Artificial Intelligence. This webinar is organized by the IFCC, the International Federation of Clinical Chemistry, of which I am honored to be a member of the Executive Committee. The combination of artificial intelligence and big data promises to revolutionize healthcare by improving efficiency, diagnostic accuracy, and treatment personalization. Overcoming these challenges will require collaboration among healthcare professionals, data scientists, engineers, regulators, and other stakeholders to ensure an ethical and effective approach. Managing and analyzing large data sets will be crucial to identifying patterns and improving diagnostic accuracy. The creation of sophisticated machine learning algorithms will allow for more accurate interpretation of laboratory results, aiding in disease prediction and personalized treatments. On the other hand, the application of big data in leukemia involves massive analysis of genomic, clinical, and laboratory data to identify patterns and trends. Similarly, artificial intelligence in the diagnosis of diabetes mellitus involves the development of algorithms that can analyze large amounts of clinical, biomedical, and lifestyle data. Today, we will explore these topics in 3 excellent presentations that we will now proceed to deliver. So let's introduce our first speaker. Antonio Buño is from Spain. He holds a degree in medicine and surgery from the Autonomous University of Madrid. He is a doctor of medicine and surgery from the Autonomous University of Madrid with an extraordinary doctoral award. He is a specialist in clinical analysis at La Paz University Hospital in Madrid, Spain. Currently, he serves at the head of the clinical laboratory service at this hospital. He is the director of the point-of-care testing program at La Paz Hospital. He is the president of the Spanish Society of Laboratory Medicine. He is the president of the board of trustees of the José Luis Castaño Foundation for Laboratory Medicine. He is a member of the IFCC's Congresses and Conference Committee and a member of the organizing committee for the upcoming EuroMedLab 2025. In Brussels. Very well. First of all, I would like to kindly thank you for the invitation to participate in this webinar, and if you allow me, I will share my screen to spend the next few minutes discussing the future of laboratory medicine. This is the design of what our hospital will look like in a few years, completely renovated, and I present it to share a small anecdote. The question that I consider to be the most difficult I was ever asked in my professional life was when the heads of service at our hospital were asked how they believe their service will be in the next 30 or 40 years, as we were designing the functional plan for this new development. It is truly a question without a concrete answer. It is very difficult to search the literature or references to answer it because we do not have a magic ball, a crystal ball, where we could ask and it would answer what the future of laboratory medicine will be. The most we have is personal experience, the experience of our colleagues, our predecessors, where we can see how the laboratory has evolved over the last 10, 20, or 30 years. And from that evolution, we could think or consider making an extrapolation. But even so, that extrapolation would surely involve errors, because we don't know if we can make a linear extrapolation, a logarithmic extrapolation, so we should avoid assuming that what has happened in the last 20 years will be more or less the same level of development that will occur in the next 20 years. In other words, no one has the right answer, or in other words, the answer may be valid. Searching the literature, there is really little information on this topic. It is a somewhat philosophical question, perhaps less technical than we are usually accustomed to answering, and therefore it is easy to understand why there have been few publications, few authors who have reflected on this, although some have. Perhaps we could be helped by knowing what we don't want to have right now, what is hurting us now, so to speak. We are our biggest difficulties at the moment to see if that gives us a clue that would allow us to be intuitive about the future. Before making some brief reflections or considerations about the future of laboratory medicine, I would like to make some small considerations about what the future of the population of our patients will be. We must bear in mind that the population is expected to continue growing until the end of the 21st century, especially in the African continent, where by 2050 it is expected to represent approximately 25% of the total population of our planet. We are also aware that the population is increasingly older, the life expectancy is increasing in each continent across the globe, which leads to a greater incidence, a greater prevalence of chronic diseases. Chronic diseases will undoubtedly shape how medicine develops and other conditions that we do not know right now, nor we can even begin to guess at political, economic, or even climate change level, which will surely influence our professional future, not only in the laboratory, but in medicine and any other activity on the planet. If we recall the medicine of the P's, of the 3P's, 4P's, 5P's, 6P's, we see that we have been transitioning from a model centered on the doctor, centered on the physician, to an increasingly patient-centered model. And this concept is not new. It is something that has been happening in recent years. We have been talking about predictive, preventive, and personalized medicine. Then the term participatory was added, precision medicine, and more recently, psychocognitive medicine, perhaps learning lessons from the recent pandemic, the enormous impact that attending to mental health has. We see that in this century, and especially in recent decades, medicine is much more centered on the patient, and it is the patient who is involved in the healthcare process. Moving a little away from the model of the last century, a more paternalistic model, more centered on the physician, where it was the physician who made the decisions, who guided and advised and almost decided for patient. In reality, in 5P medicine, when we ask a patient what they would like to happen with their health, I believe we would all clearly say that the first thing we would want is not to become patients, to remain citizens, that is, not to get sick, hence preventive medicine or health care promotion. If we do get sick, we would like to know what is going to happen to us, what our future prognosis will be, and that's where predictive medicine comes in. We would like the care and treatment to be adapted to our circumstances, not a standard treatment, which is why we want medicine to be personalized. Moreover, we want to have information and be part of the process. We no longer want others to make decisions for us, but we want to be part of those decisions. Hence, medicine is participatory and population-based, meaning we want what is done for others to be done for us, not to miss out on opportunities. Another consideration to take into account before reviewing the future of laboratory medicine is the tremendous technological advancement that we have had, currently have, and undoubtedly will have. And if we look back a bit within the clinical laboratories, we can see that the growth has been absolutely exponential in terms of technology, analyzers, new diagnostic methods that are much present, more precise, much more accurate, allowing us to do much more with less sample volume. Let's also not forget the new therapies, gene therapy, CAR-T, which are already among us, And I am sure that in the coming decades, they will go from being almost advanced therapies to being almost standard treatments in many cases. Also, as the recent pandemic has clearly shown, there will be an increasing demand for preventive medicine services, greater attention to public health. We will need to be alert to see what role the laboratory medicine can play in preventing diseases, not just in diagnosis or prognosticating or monitoring diseases. It is well known to everyone, but it will not be foreign to the future. The enormous cost pressure we are under worldwide for one reason or another. We are increasingly asked to do more with less, with fewer economic resources, with fewer human resources, even with less space. And this is a trend that I am convinced will not only continue in the coming years, but many even worsen. We have already been suffering from significant laboratory integration and consolidation in many locations or parts of the world, and this trend will continue. I am sure it will continue to form increasingly large, capable and sophisticated laboratories, which paradoxically will coexist with what initially seems incoherent, which would be greater centralization coexisting with decentralization. And this decentralization would go hand in hand with what is known as point-of-care testing, which again, with what we have learned from the pandemic, we must go hand in hand with telemedicine, that is, other ways of practicing medicine, bringing medicine closer to the patient, and the laboratory must accompany all these movements. And we also cannot ignore direct-to-customer tests, DTCs. We must ask ourselves whether a doctor's prescription will be necessary to perform laboratory tests, something that already exists at this time, that can already be done for multiple uses in multiple locations around the world. And obviously, we cannot ignore it. If we focus on the future of laboratory medicine and divide it into the three classic phases, pre-analytical, analytical, and post-analytical, it is certain, in fact, there are already a few examples that we will see tools based on information systems, artificial intelligence, machine learning, among others, that will help us recommend which tests are most appropriate for the patient's situation at a certain moment, based on pre-test probability, based on clinical evidence. There are enough exercises and examples to understand that this will gradually become a standard of use in all our laboratories. There are also examples of robots that obtain samples using ultrasound systems for blood vessel detection. They could obtain samples automatically. Today it seems a bit like science fiction, but there are already some examples where they are functioning with the undeniable advantages they could have. It will also happen that we will need less and less sample volume to do the same things or even more things, as we have been enjoying for some time now. There will also be the possibility of decentralizing sample collection, that the patient can obtain their sample with devices as simple as those we can see in the photograph, and that sample can be sent to a laboratory, thus simplifying the perceived quality, improving the perceived quality for the patient, and facilitating and enabling tests that otherwise might be more challenging to implement. The use of drones for collecting and delivering samples is something already being carried out in multiple countries in different latitudes, and it will undoubtedly be a possibility that we will see more developed in the future. Just like the use of alternative matrices and samples such as saliva or dried blood on paper, as well as the use of algorithms that detect errors in the pre-analytical phase, we all know that the phase with the highest percentage of errors occurs in the pre-analytical phase. There are already various algorithms and tools that can help us detect errors differently from what we are used to using in our laboratories today. In the analytical phase, we will need to be increasingly efficient, as we have been for several decades. There will be greater consolidation for analytical activities, even pre-analytical and post-analytical, on platforms in total automation systems. It will be possible to use robots. Some countries are already using them, as we can see in that small photograph. Robots for routine tasks such as transportation of samples from one location to another. Automation and robotization will continue to expand and be applied to many other disciplines, such as genetic laboratories, microbiology laboratories, where the first models have already started to appear some years ago. But obviously, all this technification and implementation of currently available technology will gradually become more prevalent in all laboratories. Just like the integration of information systems at the hospital level, we know that laboratories generate the largest volume of data, and all that data, meaning patient results, must be combined with the massive amount of data generating within analyzers, which should allow us to use other types of tools to analyze the data, improving results, detecting errors that may currently be very difficult or sometimes impossible for us to detect. Also, from an analytical point of view, new technology will continue to be incorporated. If by new technology we consider mass spectrometry, but I am convinced that in the coming decades we will finally see the expansion of this technology incorporated into the routine activity of our laboratories. It is not that it doesn't exist at the moment, but it is true that its utility is more limited on the one hand, and not all laboratories have adopted it, possibly due to the difficulties in handling it, the complexity that may exist. But as this technology is gradually simplified in a certain way and open up to the measurement of other types of molecules and other clinical applications, it will expand, I have no doubt about it. And everything related to omic, genomic, transcriptomics, proteomics, metabolomics, and the omics, so to speak, will be established in the coming years, and we must gradually change the way we think. We must move from measuring biomarkers to measuring panels of biomarkers, from measuring target molecules to measuring molecules or profiles, such as mass spectrometry profiles, for example, that clinically adapt the needs and utility required by patients, but which will evidently be a different way of thinking from what we are used to at the moment. In the post-analytical phase, we expect far superior integration of results and data into the patient's medical records than we currently have. We must transition from the traditional laboratory report, in some cases with incomprehensible results, certainly for patients and sometimes even for the physicians who request them. That report model is numbered or counted, but obviously we will not continue to report our results as a test name, result, units, and reference interval. That should gradually be replaced by algorithms and artificial intelligence systems that help interpret results, that explain to a patient, so to speak, all this massive amount of information, and if possible, combined with complementary imaging tests, with other complementary tests, or with other relevant clinical information about the patient. Personalized reference values should also be developed. Current information systems are not yet capable of handling this amount of information, but I would like to see my results compared to mine within 10 years, not to a similar population that may resemble me. That is a reasonable expectation, something that is possible based on biological variation criteria, possibly, but there are people working on this type of information that will be extremely relevant and should help the clinician interpret the results in a much more kinetic way than the static one we currently have, which is looking at the report of results that we all generate. Excellent reports, no doubt, but in the end, we are only seeing what is happening at a specific moment in the patient's care process. Undoubtedly, everything related to data science and laboratory medicine will have enormous prominence in the coming years. It is already gradually gaining more importance. We are becoming aware that it has been with us for several decades, but evidently the rise and the technological possibilities we have at the moment will gradually be applied, and we must incorporate all those artificial intelligence tools, machine learning, big data, both inside the laboratory to help us improve our process, but especially outside the laboratory to help us provide value, to avoid limiting ourselves to being mere generators of reports and results. All these tools will undoubtedly come to revolutionize the future of laboratory medicine, and in response to the fear and question that often arises, will all these tools end up replacing us? Well, I would personally dare say no. They should not replace us. Just in the past, many other technological tools did not replace us. What they must do is complement us, and we must be prepared to receive them, adopt them, and incorporate them into our daily work to improve the service we provide to our patients. Other things will change as well, such as the approaches to quality management systems. The quality assurance of today will surely not be the same as what it is now, just as it is not the same as it was 20 or 30 years ago. Internal and external quality assurance models must evolve. As I mentioned earlier, we generate a huge amount of data within the laboratory that we must be able to exploit. And once properly exploited, they will surely replace the tools we currently have. Similarly, our quality indicators, our KPIs that help us assess the performance of our daily activities, are already evolving but must continue to evolve. We must ensure that the laboratory is not measured in terms of activity, in terms of the number of tests we perform, the number of patients we attend, see, the patients we assessed, even the number of tests we have voluntarily added or stopped performing. Instead, we should start being measured in terms of clinical value. Not the number of glucose tests we perform, but the number of diabetic patients we diagnose. Not the number of other tests we perform, but the number of patients with liver diseases we uncover, hidden diseases that we bring to light through the work we do in the laboratory. I am convinced that the tools we are already starting to have at our disposal will help us achieve these indicators and implement them in our daily work. We cannot overlook the importance of everything related to green laboratories, sustainable laboratories. We cannot afford to ignore whether an analyzer consumes more or less energy, more or less water, or occupies more or less space. This is an example of a guide published by the European Federation of Laboratory Medicine for the implementation of a green laboratory certification. And well, whether with this help or any other, it is something that we must ethically consider, not just from the laboratory perspective, from a medicine perspective, but ethically we must consider it because we must be aware that healthcare services, medical services, are enormous consumers of our planet's resources, and it is in our hands to prevent or preserve these resources as much as possible. There will also be new ways of communication and interconnection, both internally and externally within the laboratories, communication with our colleagues from other specialities, something that will surely happen in super specialization. The technological development increasingly demands more of us, really requiring us to know more about very specific areas, making it impossible for us to know everything. And we must recognize with humility that we cannot know everything, and not being able to know everything will require greater contact, more teamwork, more interdisciplinary work. And allow me to make a small distinction between the difference between multidisciplinary and interdisciplinary work, which are often confused as terms, as I allow myself to point out this detail from this article that I present to you, where the main difference is that with interdisciplinary work, working together with other specialists from clinical specialties, from other disciplines, even not medical ones, nurses, or many other professionals. We are able to learn from them. And that learning modifies our way of working. This must be the most important difference with multidisciplinary work. And as I said, this super specialization will require and need increasingly interdisciplinary work. Of course, there will be new ways of training, new trainings that we must adopt, as well as everything related to research. Research in the future will not be like we know it now. Basic research, translational research, clinical trials, I am convinced they will not be. In fact, there are already enough publications that foresee a different way of conducting research, much more efficient, faster, agile, and from the laboratory medicine perspective, must be prepared to meet these needs. To conclude, in this article, I present and recommend. I really liked the reflections it made. In the upper graph, we can see a typical innovation curve, what it would look like. When we innovate, at first, we see that it takes us even extra effort to do the same thing we used to do. Then we move to a phase where we are much more productive. We see progress in our process and procedures up to a limit. Well, our daily lives, as you can see in the second graph, consist of small innovations or should consist of small innovations. We increasingly have more precise analyzers that consume less sample volume, have fewer errors, and all these are small innovations that undoubtedly improve productivity and work in our daily lives. Suddenly, an innovation might appear, such as the emergence of mass spectrometry, which could, as seen in the second graph, modify that trend and enhance the total innovation process. And there are also changes that are more than just innovations. They are disruptions, and possibly we are currently immersed in a major disruptive change, which is the arrival of artificial intelligence, all the data science tools, both in medicine and of course in laboratory medicine. And we need to avoid what this author mentioned in the article, what happened to some companies. I'll mention some names. It is from this article, taking this information from this article, Xerox, Kodak, Leica, Nokia, etc. Companies that we all remember as great companies, market leaders in their sectors at one point, but by not knowing how to adapt to those disruptive changes in their moment, it in its own time either disappeared or significantly diminished. So we need to have enough flexibility, which we have demonstrated through this pandemic, to adapt to future changes, whether social, demographic, or new ways of practicing medicine. In summary, this is a table from this publication by Dr. Plevani, Dr. Laposat, and Dr. Lippi, which more or less summarizes all the points I have been mentioning about how they see the laboratory now and how they would see it in the future, and a series of recommendations they give us to transition into that future. While preparing this presentation, I came across this recent publication in Nature, where this author, a professor of oncology at the Johns Hopkins School of Medicine, said that, and I liked it because of its connection to our speciality. She said that she believed that within 25 years, there would come a day when, with a simple laboratory test, we would be able to report the risk of various diseases, diabetes, cancer, etc., that could have easy interventions available. In other words, people outside the laboratory can visualize that with a small amount of blood, we could be able to provide a lot. We will see it or not, we don't know. Time will tell. And the million-dollar question, are we ready? Are we prepared to face this future? Obviously, we must act as soon as possible, and I would like to conclude with this recommendation. To view and improve our processes and procedures, sometimes we need to know how to stop. A typical mistake we all make and continue to make is focusing so much on our daily tasks that we don't even stop to analyze what we are doing, analyze what we can do, what we can change, or what is coming that could significantly improve our processes or procedures, always focused on benefiting the patient. That's all. Thank you very much for your attention, and I am happy to answer any questions that may arise. Thank you very much, Antonio, for your presentation. I believe it really invites reflection on what our role is in the future of laboratory medicine. I think your presentation leaves many questions and queries. Speaking of questions, we have one question, and it says, what would be the main key to success for us to have a bright future in laboratory medicine? Well, it's really a bit of a summary of the entire presentation. It is a very difficult question to answer, but I would dare to summarize it in 3 points. I would dare to say that everything we do must always be patient-centered. We must not lose that compass, and that should be the compass, the GPS, that we should always guide us in any action we take. It's true that it's valid for the future, valid for the past, and valid for the present. But I believe it's a message we must never forget. To not forget that laboratory medicine is medicine, and we are there to attend and improve the lives of our patients. Not even so much focused on the patient, but focused on the patient and the citizen concerning all the tasks of a disease prevention that we can perform. Secondly, I would say that we need to know how to adopt new technologies in an innovative way. Invention is something new that does not exist, but innovation is doing the same thing differently. And we need to know how to incorporate these new technologies to do the same things. Massive sequencing, if we were talking about genomic medicine, mass spectrometry, or other technologies that are emerging, knocking on the door, and in the future will surely arrive in our laboratories. We must know how to adopt them, and undoubtedly something totally disruptive, as I mentioned, is knowing how to apply and adapt data science tools to the laboratory, to our daily activities, to provide value, true value to our patients, to our results, and ultimately to our colleagues from other specialties who will be the ones attending to the patient. So, in summary, let's focus on the patient, adopt new technologies, and apply artificial intelligence tools. Absolutely agree. A very good summary of your excellent presentation, Antonio. Let's continue. If it's all right with you, now with our second speaker. She is Dr. Carmen Gomez de Leon. Dr. Gomez is a specialist in proteomics, microscopy techniques, and bioinformatics. During her postdoctoral research, she focused on breast cancer and the effects of environmental pollutants performing in silicon protein identification using database software and bioinformatics tools. Currently, at the Federico Gomez Children's Hospital in Mexico, her research focuses on leukemia, autoimmunity, and allergies. Her objective is to integrate immunophenotyping data into the Euroflow Leukemia database. Dr. Gomez de Leon is a member of the National Research System, has published 11 articles, 8 book chapters, and is actively involved in both national and international conferences. So now, I invite you to continue with the second presentation. Carmen, please share your screen and begin your presentation. Thank you very much for the invitation and thank you for the introduction. Please give me a second, I will share my screen. Thank you. Well, I will be talking to you about how we are integrating big data into childhood leukemia. As Eduardo kindly mentioned, I work at the Federico Gomez Children's Hospital in Mexico, so we focus on childhood leukemia. I would like to start a little with the incidence, mortality, and prevalence data of this disease in Mexico to give you some context on how much information we have at hand. So, well, leukemia, these data, It's important to mention that it covers all age groups in Mexico. Among cancers, it ranks number 9 with 6,955 new cases per year, 4,786 deaths, and a high prevalence, as we can see here, by sex. The incidence is slightly higher in men than in women, and the mortality rate is 3.6 per 100,000 inhabitants. So, as you can see, it's not a disease with a high incidence. But if we focus only on children, it is the leading cause of death in children aged 5 to 14 years, the sixth leading cause of death in children under 5 years, and it accounts for 70% of all childhood cancers. Here I present data from our hospital from 2011 to 2021, consistent with what has been reported globally. The most common leukemia in children is acute lymphoblastic leukemia of the B-cell lineage, followed by acute myeloid leukemia, then ambiguous lineage leukemia, and finally, the least common, acute lymphoblastic leukemia of the T-cell lineage. Over these 11 years, we have a total of 1,265 cases, counting only new cases, not follow-up cases. For the diagnosis of leukemia, first based on clinical suspicion from a complete blood count that the doctor suspects the child might have leukemia, a bone marrow aspiration will be requested. From this bone marrow aspiration, a morphology analysis will be performed, an immunophenotype analysis by flow cytometry, and depending on the laboratory, cytogenetic and/or molecular biology analysis will be conducted. Additionally, a risk stratification will be done based on the patient's age at diagnosis. As we have already seen, the incidence is slightly higher in males than in females. The white blood cell count, ploidy, certain mutations, and measurable residual disease, which is where I will focus in this talk, are also taken into account. Measurable residual disease helps us detect whether or not there is a remnant of malignant cells in a leukemia patient. Therefore, no matter the type of leukemia or the treatment the patient will receive, measurable residual disease will always be part of this follow-up at the end of the induction and on certain days, depending on the protocol being followed. And what is the purpose of measurable residual disease? Well, besides what I already mentioned, it determines the response to treatment and gives us an indication of the patient's risk of relapse. It helps the doctor adjust the intensity and duration of chemotherapy or the treatment the patient is receiving. It will also allow us to assess the feasibility of an allogenic hematopoietic stem cell transplant. And as I mentioned earlier, it helps establish risk profile since the information provided by measurable residual disease currently serves to determine how likely a patient is to relapse in the future. What are the current methods for detecting measurable residual disease? These include flow cytometry, real-time PCR, RT-PCR, and next-generation sequencing. Each has its advantages and disadvantages. Here in the hospital, we use flow cytometry for several reasons. First, it is the fastest technique currently available. Second, it is the most economical. Third, it is also the only one that is standardized. And well, this standardization depends on the laboratory where the test is performed. We use the standardized protocols from Euroflow. So we have standardized the detection of measurable residual disease by flow cytometry for B-cell acute lymphoblastic leukemias. For myeloid leukemias, it's another story. So I will base this talk on measurable residual disease in B-cell acute lymphoblastic leukemias. Okay, before diving into the details of the database we are working on, I would like to remind you that big data encompasses all these groups of information characterized by their high volume, high speed, and high variability. This requires specific technology and analytical methods to transform all this data into valuable information that we can analyze. To remind you, when I mentioned the diagnosis of measurable residual disease, we gather all the clinical information of the patient, of a patient being followed up at this hospital. We have the clinical information of how the patient arrived, complete blood counts, morphology images, immunophenotype analysis by flow cytometry, and while we don't do cytogenetics here, we perform molecular biology, including translocation panels. So we end up with a lot of information just from the clinical laboratory. And with the doctors from the oncology and hematology departments, we also have the information of the treatment protocol given to the child. And from there, they send us samples for flow cytometry and translocation panels to evaluate for a relapse through measurable residual disease and translocation panels. So we have a lot of information from different areas of the hospital for the same patient. Regarding big data in pediatric cancer, many initiatives are currently making efforts to gather all this data. Many of these are clinical data, ethnic data, treatment protocol data, and there are not many initiatives specifically focused on laboratory data, particularly for diagnosis or follow-up. However, since we are aligned with the standardized protocols of Euroflow, Euroflow has several databases that were recently launched for those who may not know what the Euroflow consortium is. Briefly, around 2012, they released their standardized protocols for the first time after a process involving researchers from 9 different countries who came together to standardize protocols for different hemopathologies. I believe this is the first step towards everything else, standardization to obtain valuable and reliable information and to provide accurate diagnosis. So they standardized the detection of different hematopathies. We work with acute leukemias because, as I already showed you, it's the most common in children. We are a children's hospital, and they recently also released their databases. They currently have these 4 databases: acute leukemias, which is what we work with, chronic lymphoproliferative disorders, multiple myelomas, and primary immunodeficiencies. Now, this standardization process is not only about performing the same sample processing, the same handling, the same acquisition, etc. on the flow cytometer, but also the analytical part. For the analytical part, we use this software called IFCC, and in this software, which is from Cytognos, Euroflow included their databases. So, any laboratory worldwide that uses the standardized protocols of Euroflow and likely analysis in IFCC software can access these databases. The limitation with this database is that it is separate, right? So, we have a limitation regarding the resources and the number of times we can use these analyses through the database. That's the first limitation. The second is that they used both bone marrows from leukemia patients, speaking specifically about acute leukemia, and they also used healthy bone marrows as controls. And however, this can be an advantage or a disadvantage depending on how we look at it. They have patients globally, hundreds and hundreds of patients worldwide, and of different ages, right? So it's an advantage when you want to do a test. And the software asks you for your patient's age because it will compare it to patients of roughly the same age. It asks for the patient's sex, which is also important. However, we do not yet have this more specialized part, for example, in leukemias. It is well known that the Hispanic population has a different genetic load than the African population. So it is very important for us to have a more specialized and focused view of our patients, who in this case are Mexican pediatric patients. That's why we decided to start creating our own database, which is another thing that this IFCC software allows. Within the software, you can create your own database. So, with all the information we have, we are focusing on building the database for our patients, primarily for measurable residual disease, and I will get into that now. As I mentioned here, I briefly present to you the antibodies and fluorochromes we use, which are of course established by the Euroflow Consortium. Why do I mention this? There are other ways to do measurable residual disease and other standardizations, but it is very important that the technique you are going to use is standardized or that you have standardized it in your laboratory, because there are also laboratories that have standardized their own technique for measurable residual disease that are validated. But it is very important that before embarking on creating a database, your technique is standardized. So we always have two tubes with these fluoropores, and we will use the markers like CD45, which is a pan-leukocyte marker. I will show you the graphs of how these samples look during the analysis. This CD45 is very helpful in determining our leukocyte populations. Since we are talking about B-cell acute lymphoblastic leukemia, CD19 is very important for this specific analysis, because although we have other B lineage specific markers for this analysis, CD19 will help us determine where our B cells are located. CD10 and CD20 are also B lineage markers, but are related to maturity. And you will also see this when I show you the graphs in a moment. During the maturation of B cells, the very immature B lymphocytes overexpress CD10 and then lose it. As they mature, they lose CD10 and gain CD20, which are surface markers. We also have CD34 and CD38, which are also markers of maturity or immaturity. CD34 is more broadly shared, not lineage specific. CD81 is also a marker of maturity or immaturity of lymphocytes. And here, as you can see, all the other markers are shared between both tubes, and we only have CD66C with 123 and CD73 with 304 as different markers in these two tubes. These markers are aberrantly expressed. 66C and 123 are myeloid markers that B cells should not express. However, it has been observed that a high percentage of B-cell acute lymphoblastic leukemias are positive for these markers, 73 and 304. CD73 is indeed a B-cell marker, but B-cell acute lymphoblastic leukemia overexpresses it. So, as all these markers help us determine measurable residual disease. The analysis is somewhat complex, and we are getting to that. Here I give you an example of manual analysis in IFCC. On this side, I like to start with the normal bone marrow, so you can visualize how these differences show up. Remember, we are talking about measurable residual disease. Here, we have normal bone marrow where, with CD45 against complexity, or in this case, granularity, because these are hematologic cells, blood cells, we see how these leukocytes are arranged. Among the more or less complex parts, we have the nucleated red cells, which, as I mentioned, all leukocytes are CD45 positive. So, if you notice, the nucleated red cells are on the left side, which is the negative part. Then we have the precursor type 1, or progenitors. Here I am showing you Bs because I selected them from CD19. They begin to express a bit of CD45, and as they mature, they gain CD45. We have precursor 2, B cells, and mature lymphocytes. In normal bone marrow, or what analysts refer to as the worm-like pattern of precursor and mature B lymphocytes, if we see this, it is normal bone marrow. A bit more complex, we have monocytes, more complex, the neutrophils, polymorphonuclear cells, and much larger or more complex eosinophils. So, as analysts, knowing this normal pattern, we can then know when something is abnormal. For example, when diagnosing leukemia, we might see something like this. However, the number of blasts is much more abundant, so abundant that the other populations are lost. Here, as we are talking about measurable residual disease, we must consider that these are patients who have already undergone treatment. So the distribution in percentage of populations often changes a lot, as does the cell size. We will not see the same thing even if it is negative, like this example of a negative measurable residual disease. Even if it is negative, we won't see a normal pattern because it is a patient who has undergone the treatment. So here I show you an example for you to compare a patient with non-detected measurable residual disease and a patient with measurable residual disease, in this case 0.2%. So, as you can compare with normal bone marrow, we have the nucleated red cells. We can see the mature lymphocytes, monocytes, polymorphonuclear cells, but notice the precursor zone. Here, in this bone marrow of a patient that came out negative for measurable residual disease, we have some precursors, but they are larger than normal. And we have many plasma cells that we did not see in normal bone marrow. And, for example, in this bone marrow that is positive for measurable residual disease, we see a higher percentage in the blast zone. And you might say, well, what's the difference between these and those? That's why we have the other markers. To begin with, I wanted to show you with CD19 how we see the other populations are negative, and from the CD19 positive cells we select the B cells. Why? Because it is B cell acute lymphoblastic leukemia. So I wanted to show you these patterns that I mentioned when we looked at the maturation tubes. We have the expression of CD10 against CD20, and in normal bone marrow, we see how the most immature cells overexpress CD10 and do not express CD20. As they mature, they lose CD10 expression and gain CD20 expression, and mature cells lose CD10 expression but continue to express CD20. Comparing CD34 and CD38, these two patterns always help us a lot to delimit where our population is located. We have the most immature cells expressing CD34, which is on the x-axis, but also CD38. As they mature, they lose CD34 expression, but continue expressing CD38. And in the end, they lose both markers expression. So, these are expression patterns that we manually analyze in IFCC and that help us, and again, I repeat, this is normal bone marrow. They help us determine when we have a pathological sample. Here, in this example of a patient who came out negative for measurable residual disease, we can again see that despite being negative, the development pattern of the cells is not entirely normal. So we have only few precursor cells, some mature ones, and here you see as I wanted to show you plasma cells that we do not see here. How do I identify these plasma cells? Not only because they are a bit more complex than the precursor and lymphocytes, but also because they should not express CD10 or CD20. Regarding CD34 and CD38 expression, they overexpress CD38. If you notice, it is much higher than the normal development cells. And as you see here, this patient who is positive for measurable residual disease, we see all the cells that stay in CD10, most of them. A few start to gain CD20, but the development doesn't continue. And in 34 with 38, we see the difference more clearly. Our cells express CD34, but not CD38. So, as analysts, we must learn to determine these patterns to identify when a sample is positive or negative. Now, here I mentioned that this sample has only 0.2% of the population. To get to this point, we have to acquire, in these two examples, we acquired 10 million cells. So 10 million cells are a lot, and it requires a very robust computer to analyze all this. In fact, the computer we use was specially made for this part, as the one we had before could not analyze more than 5 million cells. So, for measurable residual disease, we are looking for one malignant cell in a million normal cells, and this is very important for medical decisions. Lastly, I wanted to show you regarding manual analysis. For example, CD81, which I mentioned is related to maturity in a normal cell, the most immature precursor overexpress CD81. Then lose it until mature cells express it weakly. And here, as I mentioned, we have these precursors, plasma cells, a few mature ones, and this expression does not look completely normal. These blasts definitely do not express it, which is not normal because they have too much CD10. And also, comparing with CD66C, CD123, as I mentioned, is a marker of neutrophils, well, myeloid precursors. So, as we see here, these neutrophils are positive for the marker, and these normal cells do not have it. Here, they do not have it either. They are in the negative zone, and here they express it weakly. So, I would say it is a reduced expression. This was just to show you all the markers, and the same happens with 73 and 304. So all these analyses that I have briefly presented you in a few minutes does not take a lot of time for the analyst. It must be an analyst with a lot of experience to be able to make these determinations and give a reliable result. Additionally, it also depends a lot on the quality of the sample collection, right? If the bone marrow is diluted, if the bone marrow is coagulated, it cannot be analyzed. Since we work with a large number of cells, we also need a large volume of bone marrow, which sometimes is not achieved in the pre-analytical phase. So we often face this part, or like the patient, depending on the protocol being followed, a detection of measurable residual disease is requested at the end of the induction, and the patient comes in hypoplastic, right? So, obtaining all this number of cells is a challenge. Therefore, from the beginning, it is a complex technique plus the analysis. As I mentioned, this is still the fastest method, taking around 3 to 5 hours, depending on the analyst's expertise. And well, what does the database help us with? The current IFCC database allows us to load the bone marrow, and instead of determining, by the marker this population is, by the complexity this population is, the database is already populated with all these images, and it will generate these images in a time frame depending on the number of cells you have, of between half an hour and 45 minutes. It will generate these images and say, oh, well, I see this, but I need or have doubts, for example, with this population. So I need you to review it. And generally, the review also takes a little time, right? And it depends a lot on the analyst and their expertise as well. Because, as you can see, when dealing with bone marrows from patients, even if they are negative, they cannot be 100% compared to normal bone marrow. So, it is also complex how this software analyzes these images through the database. And yes, the analyst must review it, check if it is a precursor or if it is not behaving normally. But even with the tools available today, the analyst still has to review it, and then they can provide an accurate and reliable result. What we are doing is this manual analysis of all the information we have gathered over the years to create our own database. Unlike the Euroflow database, we do not have a significant number of normal bone marrows because they are not sent to us, as it is difficult for someone to say, yes, I will allow you to take a bone marrow aspiration, especially in children. So we are building it from these bone marrows. As I mentioned, the most ambitious and long-term goal would be for artificial intelligence to help us integrate all the data we have, clinical data, complete blood counts, morphology images, immunophenotyping, and translocations, to reach a more comprehensive analysis and integration of the data. I also wanted to mention that we are also conducting more segmented studies, for example with positive translocations, where we are manually integrating the immunophenotype of patients with positive translocation panels, as we have seen differences in our Mexican pediatric population compared to other populations, other ethnicities. So it is very important. Oh, before I forget, another of our goals, or another thing we also do in the laboratory, is that since we have the entire follow-up of a patient, sometimes these, here I presented very clear and nice examples, but sometimes performing measurable residual disease becomes quite complex, because here I am presenting a bone marrow with 0.2%, which is a lot in measurable residual disease, but we have bone marrows with 0.002%, 0.0001%. So, identifying such a small population sometimes becomes complex. Not all leukemias have the same marker expressions. Generally, a typical B-cell acute lymphoblastic leukemia overexpresses CD10. Not all express CD19. Sometimes the very common ones express CD10, CD34. We have leukemias that do not express CD34. We are selecting them, I remind you, from CD19. Some do not express CD19, so sometimes all this becomes very complex and we have to go back to the initial diagnosis. So those 3 to 5 hours of analysis become 8 hours depending on the patient. So to ensure the bone marrow is negative or positive, because that will determine the treatment to be taken, the medical decision to be made, we sometimes have to go back to the child's initial diagnosis, see if they have other measurable residual disease samples sent, and make the comparison. So all this is currently done manually, and as Dr. Antonio mentioned, we are too busy to implement innovations. In this case, what we are doing is working on these databases that also help us, because Infinicists also help us to compare between patients. So, in this very specialized and personalized part of the patient, since it is a patient from the hospital and we have access to all the data that has been generated, the software can match and help speed up this analysis. So that is what we are working on. We had to start somewhere. It is taking up a lot of time. As you can see, it is not easy. It is not something quick to do, but that is the goal and we are working towards it. What are the challenges? The challenges are that we receive many patients from other hospitals for transplantation, and now we have nothing. We do not have the diagnosis, we do not have other ways to track the immunophenotype of these cells, so it becomes even more complex. The pre-analytical part, the quality of the samples we receive, and the time. Those would be the main challenges we are currently facing, and I believe that in addition to intra-hospital communication, inter-hospital communication must improve to access this data and provide much more accurate results. Well, just to conclude, the standardization part is very important to provide accurate diagnosis, and let's remember that all this will directly impact the patient's health. So that would be all. If there are any questions, feel free to ask. Thank you very much, Carmen, for the excellent presentation you gave. I believe it ties in well with what Antonio mentioned in his initial presentation about how the integration of laboratory information with information from other sectors of the hospital elevates the information we can provide to the patient, giving them much more integrated and comprehensive information. One question is, what is the concrete impact on the daily workload of the laboratory due to the implementation of this automated tool? Yes, it reduces the time, not so much the workload, because in the end the same number of samples arrive and the staining part, let's say, is done manually. It is not automated. It definitely takes time, but it reduces analysis time. So not having that part automated, having this tool helps us a lot because we have a morning and afternoon shift. So if we finish running the sample in the morning, the afternoon shift can quickly report it. Unlike when we did not have this tool, the report was sometimes delayed by a day. The sample would arrive and it would be reported the next day. Now it can be reported the same day. All right. Thank you. Thank you very much, Carmen. We will now move on to the third presentation of the day, which will be given by Dr. Enrique Guzmán Gutiérrez, who is an assistant professor in the Department of Clinical Biochemistry and Immunology at the Faculty of Pharmacy of the University of Concepción in Chile. Enrique Guzmán Gutiérrez is a medical technologist specializing in clinical laboratory, hematology, and blood banking. He holds a master's degree in clinical biochemistry and immunology, a PhD in physiology, and a PhD in biomedicine. His research focuses on understanding the pathophysiological basis of gestational diabetes mellitus, as well as the early prediction of this disease. He has developed several research projects in Chile with over 30 publications in this area. So, let's welcome Dr. Enrique Guzmán Gutiérrez. Hello, good morning. Today I am going to talk about how the maternal thyroid profile can be used to predict pregnancy pathology, such as gestational diabetes, using artificial intelligence tools or simply using the machine learning. In this presentation, I would first like to explain some concepts such as gestational diabetes. Gestational diabetes is defined as a state of hyperglycemia that is initially diagnosed during pregnancy through the thyroid test in glucose between the 24th and 28th weeks of gestation, that is at the end or at the beginning of the second trimester and the start of the third trimester. Globally, it is a pathology that is on the rise, reaching around 13% based on data obtained up to 2019, and particularly in Chile, where I am conducting my research. In 2015, it was also very close to this number. More recent studies show that we are talking about an incidence of about 60 pregnancies with gestational diabetes per 1,000 births. This pathology has consequences for both the mother and the fetus in both the short and long term. For the mother, for example, in the short term, there is a high risk of cesarean section and preeclampsia. In the long term, type 2 diabetes can be a consequence of having had gestational diabetes. For the fetus, there can be shoulder dystocia, macrosomia, and in the long term, obesity, glucose intolerance, and also type 2 diabetes. An interesting point is that the current diagnosis through the oral glucose tolerance test is somewhat late because by that time the fetal phenotype is already modified. Therefore, the biochemical changes and pathological processes occurring during gestation are practically already manifested by that stage. Consequently, it is necessary to generate methods that allow for the prediction of this pathology. So, within the strategies used to predict gestational diabetes, there are methods known as univariate ones, which correspond to the most classic statistical methods of comparing averages, comparing proportions, etc. This typically involves two or more groups, such as a control group and a group with gestational diabetes. However, there are other types of strategies, known as multivariate strategies, which correspond to a set of statistical tools that allow for the analysis of a large number of variables together, enabling the prediction of outcomes, such as the diagnosis of the pathology in this case. These strategies, however, have advantages and disadvantages. For example, the most common disadvantage of the univariate strategy is the low predictive value, power. For example, if you analyze fasting glucose, it has predictive capability, but of course, for gestational diabetes, its predictive power is quite low. It may be very economical, but it has low predictive power. On the other hand, multivariate strategies are characterized by having high predictive power. To unify certain concepts, multivariate analysis may change its name depending on the field. For those of us who are closer to biochemistry and chemistry, it is known as chemometrics. However, in biomedicine, the term used is artificial intelligence. These are multivariate strategies that have been used for a long time in chemistry and have also been used in medicine, but usually only within certain methodological strategies. It is crucial that all these strategies are validated both internally and externally. A review has already described this. As a research group, we summarized all the information in the field of obstetrics and gynecology, where artificial intelligence has been used to solve various problems, including predicting pathologies and predicting, for example, primary mortality, cesarean section, etc. In the context of gestational diabetes in the literature, we can observe that until 2022, in a review conducted in our laboratory, most studies are based on data obtained from clinical records, such as gynecological obstetric data. Then there are works that use data obtained from high-complexity instruments, such as HPLC, mass spectrometry, among others. There is a third, smaller group that corresponds to a mix of clinical data and data obtained from high-complexity instruments. Initially, we are interested in what happens with these gynecological clinical data, which are clinical parameters that can be obtained from clinical exams or even from clinical records, and are available in many clinical laboratories and medical centers. Different biochemical markers from the clinical history can be used to determine or predict gestational diabetes. What are the most common variables presented in these types of studies? They include mother's age, family history of diabetes, body mass index, and higher glucose levels. The most common multivariate technique is logistic regression. In fact, in biomedicine, it is perhaps the most widely used technique as a multivariate strategy. There are many multivariate strategies, and it is essential to keep this in mind. Logistic regression is one strategy, but not the only one. There are others that are beginning to appear in different scientific meetings. It is crucial, and as I will present later, to use more than one type of strategy. This issue with strategies based on clinical data is that they have moderate predictive power. That is, an area under the ROC curve of approximately 0.7 to 0.8, understanding that 1 would be a high predictive value. 65% of the studies in the literature are not validated. This is crucial to keep in mind because many studies are published for novelty but are not necessarily validated, making them interesting but not widely applicable. Therefore, there is an opportunity to improve gestational diabetes prediction mechanisms by developing and varying new methods that consider different variables and multivariate techniques. Regarding strategies based on data obtained from instruments, as mentioned, the published papers from 2017 to 2021 show that around 16.5% of the studies are from 2022. The data depends on the instrument used and the research area. This area is broad because, although we classify it as instrumental variables, it also depends on the techniques. We have techniques ranging from nucleic acid studies like microDNA, DNA, microbiome, microbiota, metabolites, proteins, molecular biology, PCR, mass spectrometry, among others. Generally, these methods have high predictive value, but a percentage of studies, around 35%, are not validated. The issue with these strategies is that instrumental methods are based on long analysis times and are generally associated with high costs because the instruments are expensive and not readily available in most laboratories. Therefore, although these strategies can be specific with good predictive power, the difficulty lies in their availability in clinical laboratories. Once again, there is an opportunity to improve gestational diabetes prediction by generating, developing, and validating strategies that use instrumental techniques that are faster. For instance, if there were an instrument that allowed us to obtain a lot of information from a sample quickly, including its analysis, it would be useful for predicting gestational diabetes early. Within our strategies, one of the methods we've tested, which allows us to obtain a significant amount of data quickly, is vibrational spectroscopy. It evaluates the interaction between matter and electromagnetism, analyzing molecular vibrations. Within spectroscopy techniques, we have infrared, including mid and near-infrared and Raman spectroscopy. These strategies are simple, quick, low-cost, non-invasive to the sample, easily automatable, require minimal sample preparation, uses low volumes, it is specific, and do not generate waste. These characteristics make this a good strategy for early diagnosis, even competing with the oral glucose tolerance test. This is an image showing infrared spectroscopy for a sample such as serum or plasma. Depending on the infrared wavelength, specific biochemical characteristics of the sample can be determined. There are features specific to proteins, lipids, nucleic acids, and carbohydrates, meaning the use of vibrational spectroscopy relates to the sample's chemical characteristics. If we compare plasma from a normal condition versus gestational diabetes, the biochemical properties are different and thus spectroscopically distinct. Therefore, by obtaining these spectra and applying multivariate analysis strategies, it could serve as a mechanism for early detection. Interestingly, we have recently been among the first to show a relationship between vibrational spectroscopy strategies for predicting gestational diabetes in pregnancy, particularly in the first trimester. Initially, using this strategy, we wanted to see if using a multivariate analysis approach with gynecological obstetric data from the first trimester could improve gestational diabetes prediction. Our objective was to evaluate methods based on artificial intelligence or multivariate analysis using gynecological obstetric data and spectral data from serum to predict gestational diabetes in the first trimester. We recruited pregnant women in Chile from the first trimester, recording both clinical and obstetric variables, totaling 63. The diagnosis of gestational diabetes was made through a prospective study between 24 to 28 weeks using the oral glucose tolerance test. From this, we obtained 54 pregnancies with normal glucose tolerance and 9 pregnancies with gestational diabetes. We analyzed the data using both unvariate classical statistics and multivariate strategies, applying data treatment with autoscaling to ensure all variables were normalized. We then tested various predictions methods, including logistic regression, XGBoost, LSDA, among others. Each AI model's performance was evaluated through sensitivity, specificity, error rates, and ROC curve analysis. Initially, we compared these two groups, showing significant differences in some variables, including body mass index, systolic pressure, previous gestational diabetes, personal history of anemia, family history of type 2 diabetes, family history of hypertension, and specifically the FTO genotype polymorphism closely associated with body fat percentage and strongly linked to the gestational diabetes group. We employed various predictive methods, here showing only the methods that yielded the best performance, with the PSDA method showing the best overall performance, achieving an error rate of 81%, significantly better than other methods, including logistic regression, which is one of the most commonly used multivariate methods. This highlights the importance of evaluating other multivariate techniques beyond logistic regression, as it may not always be capable of predicting outcomes, and other mathematical methods may succeed. Based on all these participating variables, we performed variable selection, highlighting the top 10 variables for predicting gestational diabetes. We sought to improve the error rate of around 81%. Using all 63 variables, the validation achieved an 81% rate, but by considering only the top 10 most important variables, calibration decreased slightly, while validation improved marginally. Continuing to refine the selection, we found equilibrium from the top 4 variables, achieving 87% accuracy for both calibration and cross-validation, which was a crucial improvement for us. This process improved validation performance, showing these variables high predictive power for first trimester application. It underscores the importance of variable selection, a straightforward methodology to determine if performance can be further enhanced, alongside incorporating different predictors, including clinical data and molecular biology elements like FTO polymorphism. Evaluating performance through ROC curve analysis, we find an AUC of 0.867, which is significant. Notably, excluding the FTO variable caused a drop in performance, emphasizing its importance in predicting this pathology. Our performance outperforms the average reported for clinical data studies, and it is the only validated study of its kind in Chile with superior performance compared to others. What is interesting is that AI strategies can classify, as seen earlier, to determine whether a case belongs to group A or B, but can also be used for correlation purposes. In Chile, gestational diabetes diagnosis is typically done via the oral glucose tolerance test, but thresholds for post-load glucose vary by country due to different strategies described in the literature. For example, in Chile, the threshold for post-load is 140 milligrams per deciliter, but in other countries it is 156 milligrams per deciliter, or varies accordingly. Here, using AI tools and predictor data from our study, we aim to determine glucose levels that a patient would have in the second trimester based on first trimester data, aiming to make a prediction independent of the threshold method used. As seen in the dotted black line, the multivariate PLS method for correlation achieved a Spearman correlation of 0.496, which was significant. This method allows us to estimate post-load glucose levels in the first trimester using gynecological data, allowing a simpler approach since it relies on data from clinical records. Later, we aimed to improve our analytical strategy to make it faster using vibrational spectroscopy, recruiting pregnant women in the first trimester, collecting serum samples, and storing them at -80 degrees Celsius. We conducted second trimester diagnosis, resulting in 67 pregnancies with normal glucose tolerance and 15 with gestational diabetes. Samples were prepared and placed on special plates for infrared reading using FTIR spectroscopy, producing infrared spectra from normal pregnancies and those with gestational diabetes. Using a multivariate approach, data were pre-processed, auto-scaled, and predicted using the BLSDA method, which was the best performer for clinical data. Performance was evaluated through sensitivity, specificity, error rate, and ROC curve analysis, employing various processing strategies to ensure data integrity without distortion. Here, blue represents normal pregnancies from the first trimester and red represent gestational diabetes cases. Although differences are not readily visible, chemical information classified into 3 quadrants, R1, R2, R3, may help distinguish biochemical characteristics without specifying which exact features, focusing on predicting gestational diabetes from these spectral regions. We evaluated 80 models per spectral range, totaling 320 models, finding the best non-error rate in R1 with about 63.2%, underscoring the importance of optimized spectral data pre-treatment. After evaluating all models, we achieved a ROC AUC of 0.884 with a zero method, outperforming baseline threshold compared to published instrumental data, which is highly encouraging for early gestational diabetes prediction using spectral data. In conclusion, the strategy based on multivariate methods using gynecological, obstetric, and serum spectral data from the first trimester improves early prediction of gestational diabetes by enhancing predictive power. Multivariate analysis has been successfully used to solve various problems in gynecology and obstetrics, particularly for early gestational diabetes prediction. It can also be used effectively for other purposes, such as post-load glucose prediction and second trimester gestational diabetes prediction. Future work includes exploring strategies to improve the performance of these methods, developing external validation studies, such as recruiting a new cohort of pregnant women, and testing these strategies validated in the laboratory on the Chilean population. Finally, I would like to thank the various national and international collaborators, and especially Professor Daniela Medican, the doctoral student who developed this entire investigation. Well, thank you very much, Dr. Guzman Gutierrez, for the presentation. We will now conclude today's session. It is time to close this space provided by the IFCC. Thank you all for attending and participating in this webinar. Thank you to Dr. Buño, thank you Dr. Gómez de León and Dr. Guzman Gutierrez for their interesting presentations that provided valuable information on how artificial intelligence is related to the clinical laboratory. Thanks also Dr. Farestalle for coordinating this webinar and to the IFCC for offering this excellent e-learning opportunity. Please remember that if there are any questions that were not answered during this webinar, they will be answered by email to those who ask them. Regarding the participation certificate provided for this webinar, after answering some questions about the content presented today, you can access it through a button at the bottom of the page that says Show My Scores to obtain and download the participation certificate. Lastly, I would like to mention that this webinar will also be available soon on the IFCC website, and that other new free IFCC webinars will be announced through IFCC communication channels such as email, website, and social media channels of the International Federation of Clinical Chemistry and Laboratory Medicine. Thank you very much, and see you at the next event.